all. Charles, who's going to do that?
That's work group one.
I'm sorry, start over. I was going to say, that sounds very familiar. Okay. So we're going to look at the update of the DBHDS Criminal Diversion Program with Michael Schaefer. Is Michael here? Excellent. So we're going to eat and turn off our mics and try to do both things at once.
Okay.
Thank you.
Well, I was going to tell you my presentation is sort of like a smorgasbord of forensic issues, so it goes well with you all eating. I'll wait for Mr. Quigliano to get this up and going. You all know me. I'm Mike Schaefer from the Department of Behavioral Health. I'm the Assistant Commissioner for Forensic Services. I'm here just to provide you a little bit of an update on the funding you provided, the General Assembly provided in 2018 and what we've done with that. Then Mr. Quigliano and I spoke about giving you a little bit of update. We've been funding some mental health dockets and have our first 2 years worth of data on the dockets we fund, the outcomes of that. Wanted to share that with you. And then finally, I know there's been some talk and discussion about Intercept Zero and the sequential intercept model, and just wanted to give you a little bit of what I know about Intercept Zero and what's going on in the Commonwealth with regard to that. So here it comes. So in terms of funding for last year, or this year, there were four specific appropriations that were given to the department related to criminal justice and behavioral health. The first was $900,000 in the first year and $1.8 million in the second year for the expansion of CIT assessment sites to rural underserved areas. The second, which was under T.3, was an appropriation of $657,000 for both years of the biennium for CIT training, again in rural underfunded areas. The next appropriation you provided was $1.6 million in each of the coming 2 years of the biennium to fund forensic discharge planning out of jails that have high proportions of people with serious mental illness. And the fourth appropriation was $708,663 in each of the two coming years of the biennium to fund Intercept 2 diversion programs, and you ask us to fund up to 3 programs in that area. So starting with the first appropriation, which was the CIT assessments type funding and then CIT training funds, as you can see, we put out a notice of availability of funds to the community service boards. We had 5 areas apply. We had the CSB be the applier, but again, CIT is a community program, so they have to have the cooperation of local law enforcement, the Commonwealth attorneys, the courts, and but we have the CSB be the actual applier. We had 5 applications, and you can see there who applied. These are, again, the CSBs. We had Northwestern, Allegheny Highlands, Crossroads, Highlands, and Planning District 1, which is the very far southwest part of the state. We've reviewed them. Unfortunately, the applications were pretty weak, meaning the communities just really aren't prepared to start a program. So we're right now in the midst of providing a lot of technical assistance. They asked for things. They didn't ask for things we know they're going to need. They asked for some things in the wrong categories. They hadn't had all the partnerships established, so we're working with them to do that. Our goal is to fund all 5 that applied, and that is my honest goal, is to fund them all. So that's where we're at with that. In terms of the funding for the discharge planning, you gave us $1.6 million. We put out a notice of availability of funds, received several applications. 2 jails were selected. We funded the CSBs, but they were the CSBs associated with jails with high proportions of people with serious mental illness. So the 2 jails were Hampton Roads Regional Jail, and you can see the associated CSBs. In both cases, we had one CSB who agreed to be the fiscal agent for the whole region, but the other CSBs will be the actual provider of the service. We have the Hampton Roads Regional Jail, and then we have the Southwestern Virginia Regional Jail Authority at all their facilities. They operate several facilities.
Mr. Chair, can I ask a question? Yeah, Michael, on that point, there was a reporter this past session that told me that there was already discharge planning at the Hampton Roads Regional Jail.
Yes.
Are the state dollars replacing local dollars for this, or?
Those were also state dollars. That was part of the funding for remember the General Assembly funded 6 mental health pilot programs in jails, and that was one of the jails, and part of that funding was for forensic discharge planning. We've
Okay.
worked with the Department of Criminal Justice Services because they're the ones overseeing those funds, and let them know we will be putting these funds in, and it will essentially be supplanting existing funds, and that to work with Hampton Roads Regional to either send the money back or propose other uses of the funds in that jail. So we're not double dipping. In terms of rural Intercept 2 diversion programs, we put out again a notice. We had four areas applied. 2 were good that we decided to fund, which was Northwestern and Mount Rogers. And again, Intercept 2, if you remember, that's post-arrest, either pre-booking or post-booking. So the person's not divertible at that point of arrest, can't really divert them through a CIT assessment site. They're going to go towards jail. And so you usually wrap services around the person, not to make it a special condition that these people are now bond eligible, but sometimes they weren't bond eligible because of the conditions of their life. But if we wrap services around them, they now become appropriate people to be released from jail. And the 2 CSBs were Northwestern and Mount Rogers. We still have funding for one more program, and just 2 weeks ago, I let the CSBs know we have funding for one more program, and I'm seeking more applications for that.
Are you funding the services or just having someone there to help connect the person up with the services?
Most of it is actually for the staff to connect for the
Yeah,
services. I mean, these are, if you look at 600,000 divided by 3, it's 200,000.
That's always-
There's not a lot of money to buy services. The only thing I'll tell you where we may have money to buy services is again in that forensic discharge planning, because you gave me lump sums for 2 years. I'm already halfway through a year, so I'm gonna have some one-time dollars that will work with the CSBs to look at how we could use that money to actually purchase services in one-time increments. So again, we can't sustain those services, but we don't want that money to go to waste, so we're looking at creative ways we can use those funds. So that's where the money is. So we've got almost all of it out, except for, again, one more rural Intercept 2 jail diversion program is left to go. And again, the forensic discharge planning, or the CIT, we've got the applications, we're working them on with technical issues, but we've been successful in moving the money through. Next, wanted to switch gears a little to mental health dockets. You've heard from Judge Goodwin, you heard from Judge Talebi through the years on this issue. Just wanted to give you a little bit of update from our perspective. Again, I'm not going to belabor this, but dockets are really designed to quickly identify and move people through the criminal justice system and connect them to services. In Virginia, most of our dockets are post-plea. Some jurisdictions, other states, are pre-plea, but in Virginia, we tend to do post-plea. And the goals are to identify people quickly and connect them to services and look at what are the sort of mental health or behavioral health factors that contributed to their involvement in the criminal justice system and address those so they don't continue to be involved in the criminal justice system. Participation is always voluntary. There's frequent hearings before the judge so that you can address good performance, because again, we know positive praise goes a long way, so they give them a lot of positive praise, but also to address noncompliance. And as a safeguard, just always remember the Commonwealth attorney has to agree that someone is eligible for the docket. So, it's not as if, there's an override. The Commonwealth attorney has to say, yes, for this community, this is an appropriate person to go on that docket. Why were they created? Again, research has showed that there's an overrepresentation of people with serious mental illness in the criminal justice system. Dockets are primarily for public safety. I mean, you often don't hear that from mental health people, but it is really a public safety initiative in that it helps address those criminal factors that are causing that person to become involved in the criminal justice system. They're also designed to increase people's engagement in treatment, decrease recidivism, decrease risk use of the crisis system on the behavioral health side, improve quality of life, and hopefully decrease costs over time. In terms of what national research has shown about dockets is that people who go into dockets nationally again tend to not have as many more, they don't have new offenses as often as people who are not in dockets. Those who do reoffend, they tend to reoffend later, so they don't do it as quickly out of the gate. When we look at people who participate in the docket, what we see is their pre-arrest rate. So if John was being arrested 6 times a year prior to involvement in the docket, after involvement, it tends to go down. It may not go to 0, but it's generally lower than the rate they had. Recidivism rate is 10 to 15%. When you compare that to National Statistics Bureau of Justice Assistance cites a 3-year recidivism rate about 68% nationally. If we look at Director Clark's recidivism rate, we know it's about 25%, but he has a differential for mentally ill persons with mental illness. It's about 35 coming out of his DOC facilities, and the recidivism rate for people coming straight out of jail is about 50%. So again, the 10 to 15% is much better than the recidivism rate we're seeing either nationally or even from what we're seeing from our own reports here in Virginia. People who go in the dockets tend to have access treatment and tend to be high participators because, again, you have that lever, you have the carrot and the stick. You have the judicial sort of encouragement to involve themselves in treatment. They tended to get more intensive services. They had fewer crisis episodes. And while initially dockets were designed and the thinking was it would end up saving states money, the results are pretty mixed on that because what they're finding is some of the people going to the docket have very high intensive needs in terms of behavioral health needs, and so you're having a high cost over here, and what we know is jails are cheaper than behavioral health costs, and so even if you're saving jail days, it's not offsetting the behavioral health costs. So let's talk now, that was nationally here in Virginia. As you all know, we've had dockets for many, many years. They sort of became more formalized in 2016 when Justice Lemons issued the Rule of Court 125 that allowed for the development of specialty dockets. We did, as an agency, Department of Behavioral Health, back in October 2015, we were awarded a federal award for dockets. It was a $750,000 over 3 years, so it's $250,000 each year, federal grant to work with dockets. We started funding the Roanoke and Salem and then Stanton and Augusta in 2016. The federal funding has since ended. We've sort of cobbled together little bits of nickels here, dimes here to give them a little bit of money, but we're not funding them to the level we were in 2016 and 2017. And so what I'm going to present to you today is the data from fiscal year 17 and 18. So we've had, in those 2 years alone, out of those 2 dockets, a total of 155 people come through those dockets. Here is just in terms of who's coming to the dockets. You can see it's more male than females.
Back to what are we buying? Is it staff to help attend the dockets and then do follow up and sort of connect up the services? That doesn't provide services as much as
a very small portion. I think one of the programs uses it for some transitional housing. So if someone's homeless, they put them up in a hotel until they can get there. Vast majority of the expenses on people, yes, okay, to connect people. I think Judge Levy talked about having a docket coordinator. I think Judge Goodwin sort of said the same thing, and so we fund that coordinator because that's just sort of an unfunded position in our system, and that takes a good portion of it. So you see, male and female, more males than females. You look at the race, ethnic background, predominantly more Caucasian. When you look at the referral source, most of them are being referred by the judge. That's the top left pie chart. It's usually the docket judge or some judge says, hey, this person might be better for docket, and they move them to the docket. And then again, a docket is just a specialized grouping of cases within the court's normal framework. So it's really not like a special court, it's just a special docket that they hold. But you can see probation, parole, probation and pretrial has referred some people, private attorneys sometimes refer, and sometimes public defenders. But the vast majority is the judge saying, this looks like a case that would be better solved through docket. You look at the charge categories, and again, you can see the vast majority are for property crimes, but I'm pointing you out, and we'll talk a little bit later about the violent crimes, which is in green. 29% had some kind of violent crime. Again, the judges have told you before, these dockets tend to exist in general district court, so most of the people are misdemeanors or felonies that were pled down to misdemeanors. And so it's not going to be a murder charge, generally speaking, in that violent category. It's going to be an assault that was either, well, assault on URI would be a misdemeanor, so it's usually assault, might be assault and battery on a police officer what's been pled down. You can see, again, the bottom pie chart in terms of the charge type, about 75% are misdemeanors and only 25% are felonies. In terms of, again, who's in these dockets, you can look at the diagnoses. The vast majority have a mood disorder, although you can see about 17% have a psychotic illness, and then you can see all the other disorders. When you look at secondary diagnosis, so sometimes people have more than one diagnosis, so you list the primary one first and secondary, sort of the second most salient diagnosis. You can see about 37% have a coexisting substance abuse disorder. That's lower than what we know nationally. About 70% of people with serious mental illness have had at some point in their time a substance addiction issue, but we're seeing about 38% have a current substance addiction issue. In terms of screening, so just because someone's referred to the doctor doesn't mean they always get in, but you can see the vast majority do, 75% of them do, and then you can see the very reasons why. I'll point again, the prosecutor declined, so again, the prosecutors are actively involved in this so that they are opting some people out saying, no, I'm just not comfortable with this person going to this docket. You also see somewhere the person didn't have a mental illness, so they didn't have the requisite, because these are dockets for mental health issues, so if they don't have a mental illness, they don't go into the docket. And you can see the other various reasons people were declined. Moving on to criminogenic risk. So one of the things we look at is when they set up any of these diversion programs, you try to get more moderate to high risk people. And so moderate and high risk in terms of failure to appear or risk of reoffending while they're out in the community, because that's where you're trying to really impact. You know, some research and some people who have been real supporters of dockets have sort of backed away a little in terms of they're afraid we get too many low-risk people, because what we know is if we over-program low-risk people, some low-risk people would just done well anyways. And so are we really affecting things? And sometimes if you take a low-risk person, you over-program, you can actually make them worse. So I think Delegate Bell has a question sometimes like, why would someone in the right man do a docket? You're sort of getting yourself into a year's worth of following. So we try to get the moderate to high. You can see about half the people are low risk and the others are moderate to high risk. The way we assess risk is through the VPRA, the Virginia Pretrial Risk Assessment Instrument, or the OST, the offender screening tool that probation parole use to assess risk. So of the 150, so now we're getting to sort of the results of what the data has shown us. So of the 155 docket participants, 29 did have prior arrests prior to the current arrest. So, you know, they're in the docket on a current charge, but they had an arrest sometime in their background.
All right, pause there, please.
Sure.
So that is not what I would have thought. I would have thought that these are, we know them by name, first name, last name, very frequent participants in court, and we tried the less significant mental health docket, and we just run out of other options, and so everybody says he'd be perfect for it.
Yes.
Is it possible that that is low, or am I just misvisualizing who is actually getting into these dockets?
I was shocked by this like you were. I thought it'd be that same person who, John's been here 17 times on trespassing. He keeps trespassing. Let's try something different. I haven't gone back. I need to scrub and dig down in this and figure out why is it this way. And if I'll talk to the judges to figure out why are we getting so many sort of new people versus people with known criminal histories. I don't know the answer.
Okay, I would find that useful, because if it's a bunch of people that have never been in trouble before, that is not, I think, what, I mean, this is a pretty specialized idea, and it's for people that the system just doesn't work for. Okay, thank you.
What I do want to draw your attention to here too is the green section in terms of, so of those who have prior offenses, 27.6% of the offenses were quote unquote violent in their past. So again, it's not the current charge, but they had at least 27% violent offenses. In terms of, you know, what happens when they're in the docket, again, 20% had some kind of arrest before their enrollment. During the actual docket, that drops to only 14%. Now, again, this isn't a randomized clinical trial where I can say, you know, so being in the docket decreases your rate of arrest, but we're seeing this sort of trend. And then what you see is after you're finishing the program, the rate goes down to 9%. So we're seeing what we're seeing on a national level here in Virginia. We're seeing the rate of arrest goes down post-involvement in the docket. If you look to the bottom left, that bar chart, what we're also seeing when we look at—
Mr. Chair, let me, do I understand this correctly? 14% were arrested while they were enrolled in the
Yes.
mental health docket?
Yes. Yeah, and there's another slide and then we'll talk about that. So not everyone sort of corrects their way and goes on to the happy ending. Some people do it again, and then a new arrest, as you heard from Judge Godwin and Judge Talebi, was that's usually a reason to not put you on the docket because you're not taking it seriously. if you go down to the bottom chart, so again, this is a relatively small N. It's an N of 65 people who completed the docket. If you look at the average number of charges they had when they were arrested before the docket was 6. That went down to 4. That went down to 3. So what we're seeing is people are picking up fewer charges as if they go into the docket. And we also look at the number of bed days. So if they were arrested, and again, this may correlate with charges. So if you have 6 charges, you're probably gonna have more bed days than if you have 4 charges. But we're seeing the amount of time they're spending in jail going down. So it's having a positive effect on that. And then if you look at the pie chart on the bottom right, this is so if they get a new offense, what is the offense? What I draw your attention to again is only 8.7% are violent. Again, that's 8.7 too many. We don't want people violent, if any. But if we compare that to the 29%, where they had 29% violent offenses before their involvement, it does sort of imply that being in the docket might decrease the severity of the offenses you engage in. Doesn't eliminate it, but it sort of buffers people from those most violent offenses. Property offenses go up and the minor offenses go up. Again, not negating that property offenses aren't important, but we're seeming to move people from the violent offenses to the less violent offenses. So how long are people in the docket? Or how long from when they get in the docket to when they reoffend? Because again, earlier I told you the national statistics are, when you're in the docket, if you're going to reoffend, it's later than sort of your match comparison. Again, we had those 14% of people who reoffended while they're in the docket. That equates to 60% of all the people who reoffended happened when they're in the docket. But what you'll see is as people are out of the docket, the next biggest time people offend is 180 days out. So it's pretty delayed. It's after 6 months of leaving the docket. And then here's in terms of what happens in terms of their clinical services. So on the left-hand chart are all the different, what we classify as crisis services. So what we're able to do is, because we have access to the CCS data, which you heard about earlier today, and we have access to the LIS data, which is the re-arrest data, we can look at what kinds of services were people receiving on average before they were in the docket, and what kinds of services were they receiving after the docket. Realizing what we're trying to do is bring down the reliance on crisis services. Because again, if you're in the docket, hopefully you're not going into crisis because you're having people there who you can work with. And hopefully then you've established a relationship, so even when you leave the docket, you don't go into crisis quite as often because you have the resiliency, you have the resources, you have the coping skills, you've got what you needed from the docket. And what it shows is that actually, in terms of these 4 crisis services, the reliance on them does go down after 1 year post being in the docket. On the other hand, what we want to see is people using more structured, scheduled services. So people aren't going to crisis. We're not saying they don't need services, but we don't want them using the crisis. We want them using sort of the day-to-day structured activities and services. And what you can see is that psychosocial rehab goes up exponentially, so does case management. Oddly, and again, I haven't had a chance to dig into this, outpatient services goes down. And I don't know why, because that's doesn't make sense to me. So I need to do some digging and figure out why that is. But that is an oddity, that blue line in the bottom right. That doesn't make sense to me, but we will try to figure out if anecdotally we can figure out where that came from. And then in terms of why do people leave the docket, you can see that 61% successfully complete. You can see those 26% had a new they weren't participating. You can see the small percent that had new offenses. The 1 or 2 people died, and then a person or 2 absconded. You can see also the average length of time people are in the docket. I think you heard from Judge Talevi that her average is about a year, and what this data does confirm that is it ranged from 0 to 965 days, with the median of 344 days that people are involved in this. So that's it about our dockets. So I just wanted to give you a little bit of preliminary. So again, the summary is it looks like Virginia data is matching on national in terms of when people are in the docket. They reoffend less frequently. When they do a reoffend, it's longer out. When they reoffend, it's less serious crime. We're seeing a decrease in the crisis services, and we're seeing an increase in the standard scheduled services. So it's good evidence that our dockets are working like what's happening nationally, and so we should be able to realize the same kinds of results. Moving on to the final thing, which was Intercept Zero. So I know you've heard a lot about Intercept Zero, the sequential intercept model, and I think I sent you the article about the sequential intercept model that was developed by Munetz and Griffin many years ago.
Okay.
Griffin actually,
I'm going to speak for some number of us up here. Go ahead and take a step back, remind us what the sequential intercept model is, what the intercepts are, that kind of thing. Just take 60 seconds to put everybody on the same page.
sure. So I have it here, and it should be in your handouts. If you don't, I have some printed larger copies if it's not good for your vision. Well, my vision's really bad. So the sequential intercept model is developed by Patty Griffin and Mark Munetz. Mark Munetz is a psychiatrist, Patty Griffin's a psychologist. Patty Griffin actually used to work here in Virginia, used to have my position back in the 80s. What they did is when they really looked at people with mental health issues in the criminal justice system is they said there are these very identified times where you can intercept or intervene with people with serious mental illness as they move through the criminal justice system. The criminal justice system tends to work it's lockstep. It sort of moves in fairly predictable steps. And so they were saying there are these steps or these points where you can intervene. And when you intervene, there are either two goals. The goals is either to deflect or divert someone from the criminal justice system, if that's possible. Now, not everyone's divertible. If you just stab your mother to death, even if you have schizophrenia, you're not going to be divertible from the criminal justice system. So the other thing is if you can't divert, then it's to link people to services. Because what they found is either by diverting or by linking people to services, we have better outcomes in the long term in terms of decrease in violence, decrease in recidivism, and increased engagement in the criminal justice system. When I was trained on the sequential intercept model back in the early 2000s, there were 5 intercepts. So the first intercept is at law enforcement. And that's where you all have done a really good job of funding CIT and CIT assessment sites. So that's where, we try to bolster the criminal justice system at that point so that law enforcement, and again, CIT is more than training. It's about a community collaboration. But that we give the officers the skills to learn how to talk to someone who's in a behavioral health crisis. We also develop stakeholder groups that we have law enforcement and behavioral health and the courts all working together about how do we as a community want to address these issues. And we also have these CIT assessment sites because what the research had set up at that point is if faced with the option of either waiting to issue a TDO or taking someone to jail, oftentimes law enforcement would result to taking someone to jail because it was quicker. And what we know is you need to create a path of least resistance. So that's why these CIT assessment sites have security staff or off-duty law enforcement so there can be a secure transfer of custody because that way it makes it quicker. And so that therefore even the best intentioned law enforcement is going to opt for the CIT assessment site because it's not going to take him there's no skin off his nose. It's not going to take him any longer. And in no way am I blaming police officers for having taken people to jail. They have an unbearable job to police this whole community. And you heard stories about them waiting 6, 8, 24 hours in the ER waiting to issue a mental health summons issue. And so that's the first intercept. Intercept 2 is what, again, you recently defunded, which is that you can't divert at the front end, so they then either go before the magistrate or they have their first appearance. In Virginia, there's limited latitude what magistrates can and can't do in terms of their decision making, so a lot of it comes post-magistrate, so it's post-booking, but can you wrap services around someone so that when they go to their first appearance, the defense attorney can present to the judge, I know my client didn't make bond, but here's all these services we've now magically wrapped around him that are going to make it, again, so that he comes back to court, he's not going to have failure to appear, and he's not going to reoffend when he's out in the community. Those are the 2 critical issues, at least my understanding, for the initial arraignment. If that's not possible, then you go to jail. And so that's where we have dockets, our Intercept 3. But we also have jail-based mental health treatment. And so some places have special mental health teams, or they'll have specialized units, or they'll have standards for mental health, or you'll have dockets. Intercept 4 is reentry. So again, everyone who's arrested and more likely not can come back home. And what we know is if we don't link people to services, they're at higher risk for recidivism and they're higher risk for crisis. And so that's again where you have funded the forensic discharge planning, that $1.6 million this year. And the fifth intercept is, so when people are out on community corrections, probation, parole, having access to services. So making sure in some jurisdictions they will have a specialized parole officer who understands mental health issues. And so that when someone's doing something or saying something, they know, okay, this is how I respond to this, or this is how I get them services. Well, what they've done in the last couple of years is they've talked about Intercept Zero. So this is a new intercept, and they always talked about it nebulously, but now in printed papers, they talk about it much more specifically. And it's really designed prior to crisis. How can we help people so we don't have to get to the point that they even come into contact with the criminal justice system? And it's really by having a robust mental health system that's well-funded and well-functioning, and has all the services so that people don't get to the point that the police get called. And so here's some examples of some Intercept Zero. So it's both on the police side and on the behavioral health side. So you want to continue to build out the police response. CIT is a good prerequisite for Intercept Zero, and that provides the officers with the skills. They talk about homeless outreach because what we know, unfortunately, is a high rate of mental illness in the homeless population. So reaching out, not because they've committed a crime, but saying, okay, here's sort of, it's like shooting fish in a barrel. Here's a chance for a lot of people who may have mental illness. How can I engage them to get them into treatment? And then you have on the behavioral health side, community behavioral health centers. Remember, as a state, we applied for that. It was a federal initiative. We didn't move forward because it was going to be so hard to implement because we were not a Medicaid expansion state at that point. So that's where we've come with STEP Virginia. And STEP Virginia is a really good investment in this Intercept Zero. So you've already been doing a lot in Intercept Zero. Crisis centers like the CIT assessment sites. So in terms of, so what do we do and how do you do it? So again, having the well-funded system is the best Intercept Zero. It has to be well-funded and well-functioning. So it's one thing to have the services, but people have to be able to access the services and people have to know how to collaborate together. Again, funding out STEP Virginia will be a long way to doing Intercept Zero. But on top of that, some localities have created special Intercept Zero programs. So I'll talk to you a little bit about Henrico and Alexandria to a lesser degree. So back in, let me find my notes, about 2008, Henrico County just realized they were getting a lot of 911 calls, and about half their 911 calls were not really things that would constitute a 911 call. But they, like a lot of communities, were having people who just called 911 a lot. And so they worked with their criminal justice and with their dispatchers and their fire EMS and realized a lot of these people have mental health issues or challenges or something's going on with them. And so they created the STAR team. And the STAR team is a CIT trained officer, a clinician from the CSB, and usually a peer, and they proactively, they identify as a community who are these high-risk callers. And they may not even have to be 911 calls. Who do we know who's living in our community? Who's at risk for going into crisis? And rather than let it go to crisis, they do proactive wellness calls. So they go out as a team, and they do anywhere between 30 and 50 people a week that they just go and check in and say, hey, John, haven't seen you. How's things going? Any problems? So you have mental health there so if they start hearing mental health issues, they can address that. And then they also have a larger regional work group where social services, schools, everyone else is involved so that they can identify higher risk people. So it's this whole concept of intervening before there's a problem. And so Henrico, I can't tell you outcomes in terms of what they realized, except for that the county really embraces this team. They see it as a real asset. When I went to the Henrico website, there were stories from medical doctors saying, I had a dialysis patient who often refused dialysis, and the STAR team, I was able to call the STAR team and say my patient hadn't shown up for dialysis, and the STAR team was able to go out and help the person acknowledge, I need this, and get them back into dialysis. Alexandria is looking at the same model. It's not as far along, but they're looking at as the mental health agency to hire someone to do ride-alongs with the police. And again, it's sort of doing this pre-crisis intervention. So that's where Intercept Zero is. Again, we're doing a lot. We could look at funding more of these sort of pre-crisis things. When we work with our CIT, again, we fund the CIT assessment sites. This is where we're really challenging CIT programs to go is, okay, you now have this assessment site. Can you back up and somehow get people before they go into crisis to use this existing service? And that's it. Any questions?
I do, but does anybody else? I've been sort of monopolizing up here. Okay, so we're going to have a discussion in a little bit about CSBs and the relationship between them and the jails.
Yes.
And several of the things you've described, sort of the the different intercepts where we look at the CSB and see what they can offer ahead of time. And then you work out the services and then get somebody out on bond. You get them to transition at the back end. So now we're transitioning out of jail. We need to see what the CSB is offering. There are a number of challenges that have been strongly expressed to us about why it will be difficult for the CSBs to coordinate closely with the jails. On the other hand, I keep seeing how hard it is to not have them there at every step of the way, because it just seems like you have this step in the middle where, in theory, some entirely different independent mental health group is providing care that is not connected in either direction. You've got HIP issues in the transition side. At the front end, it's hard to see how you do the wraparound if you're not, every bit of it is coordinating with the CSBs. I mean, if you're saying that he'll have a social worker you can check in with once a week, and that's how we'll get him to court judge. I mean, do you have any thoughts on this? It's a big change in how we do things. It just seems like otherwise we keep hitting a brick wall of, well, that would be a whole lot easier if, we could just do this if, or we could make it happen if.
It's, you can tell I'm for a little awkward. In many ways, it makes sense. But I think part of it doesn't make sense in that you're building up a system in Step, Virginia, and CSB is already sort of tax-free for resources. And now you would saying, but now you must do this. And there's also the population in jail aren't necessarily the population who the CSB serves. Some people go into crisis in jail. They may not have an existing mental illness. They may need to service there. And if the CSB is providing it, then they would be sort of open to services leaving. And so in some sense, you may be building even more the caseloads for CSB. I think there has to be coordination. And I would think the CSBs would agree there has to be coordination. And I think that's where you're funding discharge planning is really the point. Is that because discharge planning starts the day of arrest. Because what the CSB is going to go in, and again, you all mandated uniform screening. So the jails are screening in the same way people. We haven't got to the point of doing assessment, but the jails are going to be telling the CSBs, John, Mary, and Joe have a serious mental illness. And so then the CSB is going to, they may not be prescribing the medicine there in the jail, and they may not be doing the therapy in the jail, but they're going to know John, Mary, and Joe are going to need services. And they're going to start linking with them still while they're in the jail. And again, they're not providing the day-to-day therapy, the medication, but they're going to be seeing these people. And they're going to be working with the jail to find out, well, okay, when's John's release date and where's Mary's and Joe's. And they will be doing the Medicaid application. They'll be doing the Social Security application. So in some essence, they're going to be providing some services in the jail. They're just not going to be the primary provider of the medication, the day-to-day sort of mental health operations. I think that's going to be a really vital change, and I think that's going to move Virginia a long way forward because you are, by doing that, you're embedding these CSBs into these jails for the highest risk people.
Okay. Anybody else? Thank you.
Thank you.
So next we have a presentation on crisis emergency responses expert panel from Johnny Oliver. Mr. Oliver? Yeah, and I guess in some ways this sounds like this will cover a lot of the same ground. In fact, has it entirely been covered? Exactly the same ground. Okay. So I guess if you'll step up and see if we have any questions, but I think that that's a slightly different makeup here. All right. Does anyone have any questions of the fine presentation we heard an hour ago? Thank you.
Thank you.
Okay. All right, next we have a presentation by John Jones, the Executive Director of the Virginia Sheriff Association. Mr. Jones, thank you for coming.
Good afternoon, Mr. Chairman and members of the committee. Thank you so much for inviting me. I want to talk about, first briefly, the law enforcement, and I know I'm supposed to talk about jails, but with sheriffs, we're basically the only group that deals with mental illness from the beginning to the end. The police just deal with law enforcement. The regional jails just deal with the jails. The sheriffs do the transports, and we do it all. So I need to say a word or two about the alternative transportation and how we are cautiously very optimistic about the $7 million you all put in the budget. The RFP has gone out, and I know the sheriffs are excited about the possibility of having alternative transportation. I've also seen legislation floating around that you probably haven't seeing that moves the primary provider from the law enforcement to alternative transportation. And while that seems like a good idea, I think we need to pair it with the alternative transportation before we jump and give it all together to someone else. Let's get our program going. We're excited about it. We think we can do it for the $7 million. And the mental health agency ought to be commended for the RFP and for going statewide with it. You know, there were a lot of proposals to go regional or another pilot, and you rejected that. So I want to say thank you for that. A couple of issues on jails. There was a lot of interest, and still is a lot of interest among the sheriffs for legislation to enhance the standards as it relates to mental health in local jails by the Board of Corrections. If you look at the jail standards that we have, it doesn't have a lot there for jails, for mental health. And I've had conversations with the new members of the Board of Corrections, and you know, they're looking at jail deaths, they're investigating, and they're going out. And there was legislation before the General Assembly last year that it didn't get through, but one component was standards for mental health. And I think that ought to be a priority. And it's a Board of Corrections as they relate to jails and regional jails. So we've got all of these jail standards, and jails are certified, and they are deemed to have met completion or certification. But we need to enhance mental health standards in the services provided in jail. So I hope that legislation will be back. I feel like it will be, and we'll be supporting it. That was in the form of legislation, House Bill 1487 and Senate Bill 878, Senator Donovan and Delegate Stiley. The next point, there were 3 points to my comments. The next point is the CSBs and their relationship to jails. We continue to think that CSBs ought to have a spot in every jail, and I know that they don't. Some sheriffs are using alternative services, and that's fine. But the CSBs provide services to the people in the community, and the inmates in the jails are a part of the community. I know you can say that some of the inmates are another community, but most of the inmates in jails are in that local community. We continue to advance the idea that CSBs ought to be in local jails. And I know that, you know, it's a lot of imposition on CSBs if they're not funded. But during the last session, we think we ought to be able to work out an agreement between the CSBs and the sheriffs, and upon request of the sheriff, if they want the CSB services. So there'll be a continuation after the release. With that, Mr. Chairman, that's my 3 points. And
On that last one, do you know how many of your sheriffs would like to have the CSBs in? Is it most, almost all, just a few?
I don't have a number in front of me, but I can get that. I mean, I think the CSBs are I think they're in about 60% of the jails.
Okay.
And of 40%, you're looking at resources available. I know I've heard sheriffs tell me that, well, we would like to have the CSB, but there's a contract required. We don't have the money for it. However, there is another section of the code that I advise sheriffs to rely on, provide the services to the inmates and give the bill to the locality. That's 53.1, 126. I know it's an unfunded mandate, but it's a life safety situation. It's not different than any other health care that may be in jail.
In my locality, every jurisdiction has a regional jail. So the rural ones have Central Virginia, the Albemarle, Charlottesville, Nelson use the joint complex, we call it. Do you know how many of the jail beds are are they mostly regional jails, or is it mostly not regional jails, or is it about 50-50 or?
By bed, you know, the jails are, some of these jails are tremendous jails. I'd have to look at it, but it's probably 50-50 or something. It's I would say it's not overwhelming one way or the other, because in your jurisdiction, you have a lot of localities in that regional jail, but then look at Virginia Beach, Fairfax, Arlington, Richmond, Chesterfield, where you have jails, at 1,500, 1,000, 1,500. So
Right.
you have a lot of jails that are really big jails, like the regional jails. But I can get those numbers.
And are there some, I understand, that have both their own jail, and then they have both, that like Portsmouth has?
That's right. They have a regional jail, and that's why, in some of these regional jails, what your sheriffs will do, they give the worst inmates to the regional jail, the ones that require the most services, the ones that if they are a member, they're going to use their membership for that. So that does happen.
Okay. Delegate Hope.
Thank you, Mr. Chairman. My jurisdiction in Arlington, probably about half of our inmates, if it's quite that high, but it's in that neighborhood, are from another state.
Mm-hmm.
How do the jails treat people with mental illness in terms of services for people that are maybe residents of D.C. or Maryland or some other state?
I don't think they treat them any differently than they do the Virginia inmates while they're in jail. I think it would require corroboration with the agencies when they're released, and that would require the sheriff to reach out to to their home jurisdictions. But most of my concern are those that are in Virginia. I know we've got inmates that go to other states, and the sheriffs have to deal with that just like they would the ones if they're inside the jail.
Yeah, maybe it's a better question for the CSBs. I think about discharge
Yeah.
planning. You
Follow
mentioned
up.
discharge
Yeah.
planning. How do you do the handoff? Thank you.
Okay. Any other questions for Mr. Jones? John, thank you. If you could stay close, we might have one of these, something prompts a question
I'll
for
be
you, I
around.
think. Okay. Okay, so everybody, those are the presentations. I've asked staff to, and I'm not sure that it's, oh, I'm sorry, I skipped over. Mr. Smith, I apologize. I was looking a little further down. Please, come on back. You have a presentation to make with regards to the regional jail, so good
Yes,
timing.
sir. I'll
Thank
make
you.
it very brief. Thank you
No,
very much.
Take as much time as you need.
Chairman Bell and members of the committee, thank you for letting us speak today for a few minutes. We previously, last week, sent a letter outlining some of our recommendations and as well as some of our concerns. We have very similar concerns as the Virginia Sheriff's Association does. I will start off with the adoption of behavioral health care standards for jails. We do support that. We support that being done through the Board of Corrections, which, as oversees the adoption of new standards, as well as our regulatory agency, and they audit us on those standards. We believe it's long overdue to have standards addressing mental health and medical in the jails. The standards we have now are somewhat limited, and we do support that. We would ask or urge the Commonwealth that if there is some funding that needs to be available to expedite that, if they would attach some funding to any legislation provided towards the addressing of new standards within the jails related to those two activities. The next item that we would have concern with, John already touched on as well, is the CSBs providing mental health services within the jails. We did support legislation in 2018 that was put forth by Delegate Stolley and Senator Donovan in reference to the CSBs providing those services in the local correctional facilities. We would ask that the two amendments that were in there, one addressing the funding as well as the other one which addressed upon request of the sheriff or jail administrator, we would ask that those remain in any legislation that proceeds forward. For this year, we do have some concerns, and I know Chairman Bell already brought up many of those. The CSBs, as has been spoken about earlier, are not equal across the Commonwealth of Virginia. That simply is, in most situations, due to lack of resources, which may be because of the geographical location of that CSB. Also, we currently have several regional jails that employ private contractors to provide mental health services to the inmates, as well as we have a very limited amount of jails who actually hire mental health practitioners as employees of the jail to provide those services. So the question comes up, if the CSB is going to come in, what happens to those individuals? And we would certainly not like to void certain contracts we have. In certain situations, those are attached to other contracts, such as medical provider contracts. The point was brought up earlier.
Okay, let's pause there. I want to
Yes, sir.
drill down on this. So you have a set of requirements of what you must provide in terms of mental health, and we're fiddling with those, right? I mean, start with that.
Yes, sir.
Okay. And you're the regional jails. You provide those probably mostly through contractors since you're multiple jurisdiction by definition.
Right at this point, we are attempting to find out. There is about 60% of the facilities that use the CSBs in some manner in their facility. We're trying to determine exactly what that manner is right now. There are another section of jails that the CSB is in the jails providing those services. There's another portion that has contract private employees that provide the mental health services to the inmates. And in some jails, the jail has hired its own mental health staff and then independently contracts with a psychiatrist for the psychiatric services.
Okay. And they will then transition out. Almost everybody to jail is not, I mean, it's short term, they're leaving. How can we coordinate better? I mean, it just feels like we have two completely different systems, and we're trying to use this transition
Right.
as the bridge to, I mean, you have a population which may not be your population, you got services that may not be your services, and over here you got a different population, different services, and with great effort, we're trying to get person from A to B.
Understand.
At significant expense and lots of effort because we're not willing to make them the same system.
In several cases, I can only comment in reference to my facility. Monthly, we have a meeting with the CSB officials, probation and parole, Virginia Department of Correction officials, and some other local officials, including the magistrate and in some instances the police department, of those individuals who are getting ready to transition out. My jail mental health staff, who are my employees, are also in that meeting. We share our list of inmates that come into the jail weekly to the CSBs as well. So there is a coordinated approach, at least at my facility, on the discharge of those inmates and setting up the services upon discharge that the CSB provides to those individuals, given that it's an individual that my jurisdiction's already servicing. That is one of the other challenges, is that regional jails, just by the nature of their entity, serve several regions. So which one of the CSBs is going to provide that service within the jail? If it's chosen that the legislation goes through, the jail administrator requests them to come into the facility, which one of those CSBs would provide the service? I have found that, just looking at some of the regional jails, it's just like the regional jail. I'm supposed to take inmates from certain jurisdictions. The CSBs have a similar requirement, I'm sure. So I'll pick on Margaret. So Ranson comes in. Are you able to call the CSB in Westmoreland and say, have you ever seen Ms. Ranson? She's here. We can contact them, yes, sir.
And they can share with you, you can share with them medical treatment information and that she's on.
We right now require release of information, but we haven't seen any problems with getting that information, no, sir.
From the inmate?
Yes, sir.
Okay. If she says no, you can't.
It is my understanding in certain emergency circumstances for the continuation of the care and for the best interest of the inmate that we can get that information. I don't know the
I guess let me ask
statute
it
off the
differently,
top
so
of my
I'll
head.
stop. Mr. Smith comes in. Mr. Smith has been seeing the CSB regularly in Albemarle County for 10 years. They know him well. He comes into your jail. How can we share the information if the CSB is not in the jail at the front end to say these are the meds he likes, these are the meds he doesn't like, here's the person who we see as his point of contact, and then you've got the treatment while he's at jail, which you would hope would coordinate with what he got at the front end. And then now we segue to the transition where now he's going to be back with the CSBs in 30 days. He's clean, sober, he's on his meds again. I mean, how can we facilitate this exchange of information if we're not actually going to have the CSBs in the jail?
Right now, like I said before, we request the information and we do get that information. There could be legislation that simply says that without a signed release, and I know under the federal law there is such a legislation that information can be shared. I don't have the federal statute, but
Who knows?
I
Smith comes in on a disorderly conduct charge, can't make bond. You got him for 30 days. How is it that you know that? How does CSB, do you share a list of people that are in your jail
Yes,
every
sir.
day?
we share a list, we provide the CSB with a list of everybody that comes into the facility, and they will contact us back and say, these are our clients.
We know Smith.
Yeah, we
Okay.
know Smith, and then the information sharing begins at that point. And
Okay,
that answer your question?
it does. Thank you.
Okay. Anyway, but that is a stumbling block which CSB provides the services. In many instances, in reference to what was just stated, the inmate gets out, he may not be in the catchment area of the regional jail. So I think that was brought up. What if he's in Washington, D.C.? What if he's from out of state? So he may get out and not be in the catchment area as well. The multiple CSBs in the area, we support the CSBs providing services in the facility upon request. We would like to see a little bit more delineation of exactly what those services would be, and maybe in the form of what services would actually be mandated or required to be provided upon request. And I don't know if there's any other questions in reference.
Delegate Watts?
Yes, I was basically, let me start by following up with a upon request. So what you described as far as providing a list and CSB responding, was that your initiative, or was it the CSB who reached out to you offering to look at such a list and assist?
Several, at one point I had several CSB people in my building, and that was in place before I got there. But at the former jail I worked with, we initiated that with the local CSB. And the problem comes into play is when you have a regional jail, you may be dealing with, it depends on the number of members. I'm lucky at the jail I'm at now, I have a regional CSB. And it actually covers more jurisdictions than I get inmates from. For example, the Hampton Roads Regional Jail encompasses 5 different localities. And so you would have to reach out to 5 different localities if that was the regional jail structure. My regional jail and the CSB structure match up because they're both regional.
Follow-up question,
Delegate
so
Watts.
that, again, I'm understanding that this exists just because you jurisdictionally are located, not because you're under specific contract or any other formal arrangement.
Yes, ma'am, that's correct.
On a 24/7 basis, if a inmate goes into crisis and is acting out, what are your options?
My options right now at my facility are, we have, the first option is we can call the Community Service Board, who's mandated to come in and pre-screen them and see if they're eligible to be TDO'd out of the facility to a mental health facility. Depending on how extreme the nature of the crisis is, in my facility, I have a licensed clinical social worker, I have a licensed eligible clinical social worker, and one of those is on call at all times to either come to the facility, depending on how bad the crisis is, or we also use a telemedication system. I also have a psychiatrist that's on call as well, and we can call that individual in if we need them. And once again, depending on the nature of the crisis, it could possibly be done over a telemedication system.
So I'm just wanting to clarify then that last point, those 3 mental health professionals you mentioned that are on call, all 3 of them are authorized to medicate the individual?
The only one that's authorized to medicate is the psychiatrist and or the medical doctor.
All right. Then I think my final question would be about the issue of things being formulary, of medications being formulary. Has this been an issue amongst those who come into a jail who may be on a specific medication? And what is your restriction about having the medication that they have been prescribed by a private physician available to them in the jail?
That is depends on each facility. Some facilities operate by a formulary, some do not. Every facility that I'm aware of that operates off a formulary has a means to go around and get whatever medication is necessary. There's a process to do that. I can tell you at my facility, we do not have a formulary at this time.
So how do you then dispense the medication to the individual?
When an individual comes in and he's on a mental health medication, the licensed clinical social worker speaks with him, gets the type of medication he's on. It's verified that he's on it, that the prescription is current. A call is made to the psychiatrist. She will either provide information to that clinical social worker, that I want him to stay on the medicine or I want him removed from the medicine. I will put him and see him tomorrow. Those type of things occur. But when they come in, they're screened. The medication is verified, the prescription is verified that it's current, and at that point, if it's a mental health medication, the medical psychiatrist makes that determination to either keep them on the medicine or remove them off of it.
And so the custody of the medication and the dispensing of the medication to the individual is in the hands of whom?
That is with the medical staff at the facility. Once the prescription is validated and ordered and it's put forward by the medical doctor, the psychiatrist, that medication is kept in a pharmacy in the facility. Dependent on the medication and what type it is, most mental health medications would be brought and distributed to the person at the appropriate time that they're supposed to receive those.
And I think my final question,
that's
if I may, Mr. Chairman, is, and the cost of that medication, who bears that cost?
The locality bears that cost right now. The regional jail pays the cost of the medications.
Thank you.
Yes, ma'am.
Okay, anybody else? All right, sir, Delegate Watts.
If I may, Mr. Chairman, if John Jones has anything to add to my line of questioning, I would appreciate it as far as other types of jails.
Mr. Chairman, Delegate White, what I would say on the follow-up on the standards, the bill that was before you indicated that the standard would be promulgated by the Board of Corrections with the advice of the Commissioner of Behavioral Health and Developmental Services. So I think that's where you get into the weeds with the follow-up and the transition with those standards and with the commissioner and with sheriffs, and that would involve regional jails also.
Ensure that I have closed the loop. What you're recommending as far as standards, what my line of questioning would be underneath such an initiative to have that degree of consistency throughout our jail facilities.
I'm sorry, I don't get.
If we had standards, they would in fact address my line of questioning, and so we would have a standard protocol throughout our jail facilities.
That's exactly right. That's what I'm saying. I don't know that you can write a bill to deal with
No, I
the
couldn't.
things that we're talking about, the operational, but the standards do. The standards have done that, and I think that was a part of the bill, and the bill also provided for participation with the commissioner. So that's very important.
Thank you.
Okay. All right. Now, so Charles, this is the point where we'll be looking at some of the recommendations we've had discussed over time. Is that right?
That's correct, Mr. Chairman.
Okay. So everybody, this is the penultimate meeting or the ultimate meeting? Do we have one more?
One more.
Okay. So what I had asked staff to do was actually prepare some language. Now, we may decide that we don't want to proceed that way or not. We may want to put the idea out, take public comment, and then come back to it at our next meeting. But this would also be a time when we ask about preparing legislation. Now, let me ask Mr. Jones. Mr. Jones, the Stolly bill last year about specific standards for mental health in jails.
Yes, sir.
I know it came out of I was on a committee and we voted for it, but then it never heard of it again. So something must have happened. What happened to that bill?
It passed the Senate. It was, there were a lot of stakeholders that got together, and that's when we talked about
What's the bill number?
not mandating that CSBs do every jail, because the sheriff may also, and the regional jails may also have another agreement. And the bill provided for the standards that I talked about, and it ended up not going in past the subcommittee and health, welfare, and institutions.
Charles, what the bill number? Or John, do you know what bill number that was? I'm trying
I
to
have
look
it
it up.
right here.
You said it earlier.
Senate Bill 878.
Okay. Okay, and so this had that the sheriff could invite people into the CSBs into the jail, and then this also had Yeah, BOC shall adopt standards for mental health services in local and regional jails, right?
Yeah.
Okay. If we don't pass that as a bill, is that something that is being worked on otherwise? In other words, is BOC working on that separately, or do we need a bill to make them do that?
I think we need a bill, and the reason I say that is because you'll be uniform. We won't have a hodgepodge of what's going on around the state, and you can also address mental health with deaths in jails. And I've had some discussions with the new Board of Corrections members, and they're looking at the standards, and they're even saying to me, there's not a lot there, so I think we need a bill to mandate the standards
Okay.
with mental health, and then mental health also includes, it would also include things like suicide and transition.
And that would not have to be, the CSB is a separate issue. They were in the same bill last time.
Same
You could have
bill.
one, both, neither. Okay. So I think that the first issue to kind of see if there's a consensus on would be, do we want to say there's a minimum level of mental health care that we provide in our jails? And in the past, there's certainly been concern from the jail community, but it sounds like they're there.
We're here.
I don't want to speak for you guys, but
Mr. Chairman,
Delegate Hope.
I thought the issue was around this unknown funding issue. If you create this standard, then it's a requirement across all the jails and that they have to meet it. Therefore, do they have the resources to meet that standard? If they don't, will they be out of compliance?
well, and I think
And I
that,
don't know if we know the answer to that question.
I don't know that we do
There are a
either.
couple of answers.
Senator Deeds, we've had several times when we've had ideas we thought were important, but ultimately the money, this committee, I mean,
If-
Senator Howell, Senator Hanger have more power than many of us, but we can't spend the money in here. We can just kind of say we think
Yeah.
this is a good idea.
I only
at some
raised it
point.
because I thought that was the reason why it wasn't successful last year. And I just want to make sure that if we go into this, we keep that consideration in mind.
That was my recollection as well. When you said it passed the Senate, I had thought it failed in finance.
And I see that it
wrong.
was, you are,
I thought it,
I may be,
I think it had the clause, actually.
it had
I think
clause,
that's right.
okay.
It-
It's same difference.
Right.
Yeah. Did we know how much money it was going to cost?
Well, I'm reading it, it was the combined one, though. It was both the CSBs have to go in, and there's a set of minimum requirements. I don't know if they've ever broke them into two pieces or not.
and then there's a local component that I referred to, and I think it's 53.126. It simply says, if the sheriff gets the services, enters into a contract, the locality pays it, like food, like medicine, you got to do it. And probably this is not going to happen until something like this happens. We have to do it.
Delegate Ranson.
Mr. Chairman, I've heard from my sheriffs as well, and John has brought it 2 years now. I think this is important enough that the sheriffs and the CSBs have a relationship inside of the jails and inside of the regional jails with some of these inmates so that they, when they're coming out, they also know the services that they need. So I think we need to move forward with some sort of language, and we're able to communicate and work through it.
Let me ask the super chair, Mr. Chair. Do you want us to do do you want us to actually vote on language today if we have it, or do you want us to kind of,
If you have the language, vote on it. I suspect that we'll probably vote on and the full commission will vote probably in December.
okay, so Mr. Quagliata, if you want to tell us what you have prepared, and if it fits what we're looking at, we can look at it and then actually vote on the things we can vote on and maybe put off the ones we need more work on.
Sure, Mr. Chair. I actually have 6 different recommendations. One recommendation, though, does address exactly what we're talking about, relating to minimum standards for local correctional facilities, and I can pass that out.
Yes, please.
And Mr. Chair, as you can see from the language, this directs the Board of Corrections to establish minimum standards with the advice and guidance from the Commissioner of Behavioral Health and Developmental Service and the State Inspector General. As Mr. Chair is aware, the State Inspector General is tasked with making sure that mental health services are provided, and that is why we included the State Inspector General to also, with the Board of Corrections, have a requirement to determine compliance with these standards. and having a inspection as decided necessary by the board or the state inspector general.
Okay, so let's just do these sequentially. Does anyone have any questions for staff about this proposed recommendation from the subcommittee? Let me ask, Mr. Quagliata, would it be easier to take them all up so that we can take public comment all at once? I'm visualizing 7 people speaking each time on 6 bills would be 42 speakers.
We can do that, Mr. Chairman.
Okay, so why don't you give us the rest, and we can decide if it's one we are thinking moving forward with today. What's the next one?
The next one would be a bill that would essentially do the same thing, but require CSBs to provide those services in jails. So it would be the mental health standards along with the CSBs providing services in jails.
Do you have one that just does the CSBs as a freestanding thing? In other words,
I do not, Mr. Chairman, but that language in this next one I'll hand out, if we stripped out the piece to essentially 53.168 would do that. So all that would need to be amended is the 37.2500 section.
is this then now the Stolly bill as amended, or?
Essentially, yes, with the addition of having the state inspector general participate in the standards process.
Okay. So let's not pass that one out, because that's not going to be, I mean, we could certainly pass it up, but I'm thinking that still sounds like that's more of a work in progress. What are the other ones we could do, and then we'll have everybody comment all at once?
The other one is relating to the mandatory outpatient treatment,
That was Delegate Hope's idea.
which basically eliminates the consent requirement, so.
This would allow you to go in mandatory outpatient treatment even if, over the objection of the committee, if ordered by the,
And that's an idea that I like, Mr. Chair, but if we don't have the services in the community, it doesn't amount to a hill of beans.
I don't know that, I agree. I mean, I'm not
Yeah.
sure that it does any harm. Right now, it's this, Delegate Watts.
I guess I'll do it up at the glass half full side. It may not mount to a hill of beans, but at least some sort of a post-release planning awareness of services is better than nothing. Even if the person doesn't get in there for
Charles, go ahead
3
and pass that
months
one
or
out.
whatever it may be, just making that linkage and assessing the individual, you at the very least would catch some of those in greatest need. Or perhaps those who are at a point in their life when they might be more responsive.
Mr. Chairman,
Senator Howe.
I'm just curious if we have any indication of what the cost of this would be. And hopefully we will and can recommend that we do the funding.
Let me ask staff, when do these get priced out? Is it the next step? I mean, can you get FIS by?
We can try and get this priced out by the December meeting, yes.
Okay,
Mr.
yeah,
Chair.
that makes sense, okay. Okay, Mr. Quagliata, what else?
The next one is a bill that would require, the Office of the Executive Secretary of the Supreme Court to develop a evaluation model and conduct ongoing evaluations regarding specialty dockets. One of the things this committee heard was that there does not seem to be data collection regarding the mental health docket, so this would just simply direct the Executive Secretary to collect those and report the evaluations to the General Assembly.
Okay,
I guess that would just be a step further from what the information we got just a little bit ago.
yeah, they'll be through OES, yeah, okay. All right, do you have any more, or is that it for today?
I have 2 more.
Okay,
The next one stems from the Crisis Emergency Response Expert Panel. They recommended extending the emergency custody order provision from 8 hours to 24 hours for certain individuals who are going
the
to
other one.
a specialized unit.
just, my thought is the other subcommittee heard that whole presentation on it. Why don't we hold that one until we see what the other subcommittee's going to do? I think, unless somebody wants to just take it up here. I'm not saying no, I just thought they just listened for 2 hours on that, Senator Deeds. I don't want to step on their toes, I guess.
No problem.
Okay.
And then the last one directs the Department of Criminal Justice Services to have model policies for essentially the Intercept Zero model. It was just allow the DCJS to train law enforcement on the sensitivity and awareness of persons experiencing mental health or substance abuse crises, and it was including chronic homeless inebriates, which was one of the Intercept model program suggestions.
Okay. We could pass that out. Thanks. All right, so everybody, my thought is if you have questions about these, let's ask staff now, then we'll take public comment, and then before we run out of time, we will see if there's any we're prepared to make recommendations on already and or give directions to staff for the next meeting. Let me ask, Charles, the issue about the CSBs in jail, they're sort of the omnibus, they've got to go in if the sheriff wants them there approach. Are there some issues that have arisen either today or otherwise about making it easier for them to coordinate if we don't go that far? In other words, to make it easier at the front end for the jail to tell them about it, easier at the back end to do the transition, make it easier for them to keep up with the treatment people are getting in the jail. I'm thinking of HIPAA issues or other privacy issues. If the CSBs, and I'm sure they will tell us in a minute, they don't want to be mandated to go in, what can we do to make this process work more seamlessly, given that you now have two different providers?
I'll say the updated draft did have a lot of the language that the jails was asking for in terms of being able to opt out if they met these standards that were being essentially enacted by the Board of Corrections. I guess from the perspective of the CSB, it seems as if there is information that's being communicated early on about when these individuals come to jail from the CSBs, and the idea of if there is maybe an increased discharge planning, that may make the need to have CSBs in the jail somewhat reduced if forensic discharge planning is done throughout the Commonwealth.
Are there any issues you're aware of about them being not able to share the health? In other words, person is brought in, Smith is brought in, CSB knows him well, they know what drugs help, they know, again, what providers help. We sure want that jail to know that if they're gonna have to treat him without the CSB doing it. And then at the back end, again, Smith's being released, we want the jail to be able to tell them what they did with him over the last 90 days. What, if anything, can we do to make those work better?
I understand that, Mr. Chair. There have at least incidentally been reports that there is some HIPAA concerns, and some local jurisdictions have been able to figure out how to overcome those HIPAA concerns. To the extent that those sections can be amended, we could make it abundantly clear that the information can be shared between the CSBs and the service providers in jails.
Okay. All right, anybody have any questions for staff before we take public comment?
I have one question.
Delegate Hope.
I was part of the standards bill that we're talking about. I had a piece of legislation that will require people to be treated in the jails, and a standard amendment was put onto my bill, which ultimately killed my bill in conference committee. And the language that I received from Legislative Services at the time, this goes to the question on the cost of it. They opined that until the standards are promulgated, it's not possible to project any potential additional costs. And my question then is, are we talking about a standard that is, let's see how this goes? Or are you out of compliance if you're not adhering to that standard?
I don't want to speak, I mean,
Do you know what I'm asking?
but sure, but I think you're out of compliance once it's in place. Is that not true?
So when you have a standard, you must adhere to that standard, otherwise you're...
That would be, well, I think the standards in developing the standards, they could probably take into account how they're going to phase the standards in. But yeah, I imagine once the standards are created and phase-in dates are set, if you do not meet a standard, you'd be out of compliance. Now, when you're out of compliance, I suspect that's when the Board of Corrections would hopefully promulgate some sort of remedy or some sort of, I don't want to say penalty, but some sort of, something to bring you back into compliance. And if you're not in compliance for a certain amount of time, I know the Board of Corrections can ultimately either close you down or take some other measures.
Ms. Smith, do you want to?
I think I can clarify a little bit. Once the standard is put in place, you're required to meet that standard, period. There is an excuse for not meeting the standard. If you do not meet the standard, at that point, there's a couple courses of action that you can take with the Board of Corrections. One is you can appeal the fact that you did not meet the standard. The second one is you can put into place a plan of action as to how you plan to meet that standard and remedy that situation. And then it's up to the board to determine whether they accept that. If they do accept it, they can determine if they want a follow-up visit, follow-up documentation, or something else of that nature. Thank you.
Okay, thank you.
Okay. All right, we're going to take public comment. Feel free to comment on any of the specific bills that were mentioned and/or general topics we brought up today. I know that CSBs would particularly would like to hear from them if they have some thoughts on these. Mr. Jones, go ahead.
Mr. Chairman and members, my comment would be on, I believe, the first one you passed out on the standards on page 2, where the new language is. My thought on it would be we would feel comfortable if there was a reference to that 53.126 language that where the sheriff can put the bill on the locality and they need to pay it. I don't want anyone to walk out of here thinking that the state's going to pay this when, you know, how the budget is. Most of the jail expenses are paid by the localities. So I'd like to see that language in there so that we'd have something to rely on and to actually implement the standard. It was in the old bill, and it was a point that some of my sheriffs brought up that they thought was really important. Thank you.
Mr. Jones, when you say the old bill, you mean the Stolly bill that passed?
The Donovan bill, I believe.
Donovan, that's fine.
Yeah,
Okay.
and there may have been a difference on that point, but that was in the Donovan bill.
Okay, thank you. And Charles, you would be able to find that language, I assume.
I've got it right here.
Yes, Mr. Chairman.
Okay. Yes, ma'am.
And I'm assuming, Charles, that you're going to be able to get a fiscal impact on localities or state or whoever pays by next meeting. Is that correct?
We will certainly try, Mr. Chairman.
Thanks.
Hi, tell us
Mr.
your name,
Chairman.
tell us who you're with, and tell us your
Janet
thoughts.
Arison, Virginia Municipal League, and if there are going to be new standards for behavioral health care in the jails, we would appreciate a budget amendment to go in as well to help increase the price, increase the per diem paid by the state to the jails. That was reduced back in 2009, I believe, and hasn't been increased since then, even though costs have gone up. And given that these would be new requirements for the jails, we'd appreciate that. Thank you.
Ma'am, let me ask, so in theory, you could do this by increasing the per diem for every inmate, or you could have some other special way that this is increasing the cost for?
And that would be up to the
Do you have a
people with a lot
practice?
more experience in putting this stuff together and working with the money committee staff, hopefully, to do that. But given that a high number of people that are in the local jails do have some sort of a mental health diagnosis, I think it would it'd be helpful that if it were part of the per diem or an increase of some type to the
A
jails to help
separate
them.
supplement
Yes.
for, okay.
Yes, please.
Thank you.
Thank you.
Thank you, Mr. Chair and members. I'm Katie Boyle with the Virginia Association of Counties, and I think I'll just associate myself with the comments of my colleague from the Virginia Municipal League. We would just appreciate some consideration on funding just to, strengthen that state and local partnership a little more with respect to jails. Thank you.
Hi, my name is Amanda Woodward. I'm a psychiatric nurse and advocate for the seriously mentally ill. I've been a nurse for 20 years. I've worked in a jail, prison, the ER, and an acute psychiatric unit. As far as the appropriations for jail diversion, I mean, that's wonderful, and I think it's terrific. However, when we're talking about the seriously mentally ill, there's two things that will supersede all of the, interventions that you put in place. One is the commitment standard, which is, I mean, I'm a Democrat, but I think the commitment standard is too strict in this day and age. It creates problems for seriously mentally ill people with anosognosia. They don't know that they're sick. They tend to get into a lot of problems, and to wait until they're dangerous is a ridiculous length of time to wait until somebody deteriorates to that level. They are often, neglected, and we see, brain deteriorates terribly before the chance to get any kind of treatment, is initiated. That and the HIPAA standard, the softening of the HIPAA, language. I know that's a federal piece of legislation, but I'm sure that Virginia has its own requirements, and frankly, to disallow, I don't know how. I know that it is easier than so many people make out it to be as far as communicating from agency to agency. When the care of a person is in jeopardy because you can't speak to another healthcare giver, it's ridiculous. I mean, honestly, as a nurse, wanting to take care of people, and you can't because a law is in place that prevents it. I mean, I think that's a law that needs to be reexamined. Mr. Smith's comments about 60% of jails embedded with CSB workers. I used to work at the Prince William Manassas Detention Center, and they had individuals hired that were not associated with the CSB. I was admonished for trying to make connections with the CSB and trying to get discharge treatments organized. It was considered not part of my job, and it was discouraged and frowned upon. Anyway, I just wanted to make those comments. I think that we need to just think more about the people that are really unable to care for themselves, those people with an anosognosia, and keep them in mind. They're not able to make decisions for themselves very in a meaningful way. So thank you.
Thank you. Yes, sir.
Yes, Mr. Chairman, Bruce Cruiser with Mental Health America, Virginia. I just wanted to speak in support of the first recommended piece of legislation regarding jail standards for mental health care. We would support that alone, and I think having it stand alone rather than to get into who's doing the care would be a safer way to be sure that we have to start with minimum standards, and they are minimum, but having them statewide and adopted by the Board of Corrections would fit right along, as the sheriffs and the regional jails have both said that this is something that the Board of Corrections is used to doing. It fits right in with the healthcare standards. And we shouldn't be waiting and just have them investigate deaths, but have them start with making sure that all the jails throughout the state are following at least minimum standards for behavioral health care. So we would support that. Thank you.
Thank you.
Good afternoon, everyone. Jennifer Faison with the Virginia Association of Community Services Boards. And many of you all have heard my remarks on these proposals over the course of the last session, but I did want to just say, the association is supportive of the development of standards for behavioral health care in the jails. We want to make sure that those are funded appropriately, and that the jails have a glide path, so that they can implement them and not, as Delegate Hope suggested, be out of compliance. Just make sure that there's a a good way to get them in place and to make sure that they're working and that they're appropriate. And I think you all had a very extensive presentation from Dr. Schaefer, which included some of the elements that might be included in those minimum standards, which I think the jails were supportive of as well. So I did want to make sure that was clear from the association's perspective, that we are supportive of those standards. I think what I would also like to say is that we do believe that there is a role for the CSB with regard to the jails, and that really is in that discharge planning process. Again, that discharge planner gets attached to the individual the moment that they get into the jail, and there's an opportunity there to connect to the appropriate services once they're transitioning out as well. And I think, Delegate Bell, your point often is, if we know that John tolerates X medication very well, then we'll know when John gets out that he's going to need to be on X medication. Well, I think from the discharge planner's perspective, that conversation can happen, and the CSB can know that John only tolerates X medication without actually having to prescribe and provide that medication in the jail setting. So we feel very strongly that there is a role for the CSB, again, in that discharge planning process. I am aware that many of the CSBs, I think the number that was quoted here was 60%, do provide some level of funding or of services in the jails. There are, I'm not aware of any CSB, though, that provides all of the behavioral health service in a jail setting. So, for example, in the arrangements, many of the arrangements between the CSBs and the jails, those services would focus on people with serious mental illness, which is really the population of people we would serve on the outside, so to speak, anyway. But there are not arrangements that I'm aware of where a CSB is providing every single minute of psychiatry time, every single minute of group therapy for people with addiction services. That's a very different proposition than having the CSB come in and provide services targeted to a particular population. And I'll leave you all with those comments.
All right, let me ask this. So John tolerates Risperdal, not lithium. How can the jail get that information so they can use it during the period of time that they're providing the care rather than the CSB under current law? Or is there a way?
If the, well,
you guys have had John for off and on for 10 years.
So John is a client of the CSB.
And he gets picked up and the jail has him. What information can be shared? What laws do we need to change? I would like, you know this, I'd like you in the jails. I think we're creating this Herculean weird system to get around just not having you in the jails. But if we can't do that, how can we at least get the information to the person providing the care in the jail that you know, not, if you will, the transition into jail. Where I like what you're saying about transition out of jail, but they transition into jail. I mean, can they ask you, can they send you the list of names? Can you say, oh yeah, that's Smith, he likes this, not that. He likes having, I don't know idea. I mean, he responds better to men than to women when they talk to him. Or there's a drug that he likes better than others. Or there's some significant allergies that impact his ability to process. I mean.
Understood. So I think that for the portion of individuals who are CSB clients, of course, there's going to be more information available. And I'm not sure exactly what that portion is. That was also, I think, in one of Dr. Schaefer's presentations, but I don't want to misquote it. And I think there are arrangements in place. I just was texting with a few executive directors to kind of get a feel for it. And it sounds like the arrangement where here's the list of everybody we got last night is the most common one. And are any of these yours? Kind of relationship between the jail and the CSB. I can't speak to.
Once they find it, though, what can they share? So I'm off my Risperdal because I don't like Risperdal. I don't like the side effects. I don't want you to share it. I don't want to be on it. I don't want you to tell the jail. I don't want anything. But you know from 10 years of relationship that is, in fact, the medication that is the most appropriate for my condition. I mean, can you share that with the jail?
So this is an instance where the individual is saying, don't share my information?
Right.
I don't know how that works.
Okay.
Yeah.
What's that?
HIPAA exception for treatment.
Well, I understand. I'm just asking if that's, I mean, again, the easiest answer is the CSB is there, and there's no HIPAA issue at all because he's their guy and they know him. I'm just, if they won't do that, then the question is there a workaround that will get us the most seamless kind of care that we can find? Mr. Quaglada, do you know, this is not a test. I'm not trying to trick somebody. I'm just, if,
I don't know, Mr. Chairman.
okay.
Mr. Chairman, are you asking if there's a HIPAA barrier to sharing?
Between
Information?
CSB, who treats the person on the outside, he gets arrested, they're not the provider in the jail. Can they share that with the provider in the jail? You're nodding your head. Is that a, yes,
Well, it
you,
sounds like
yes,
it's
they
a
can, or?
treatment. Go ahead.
Could I try to answer?
Sure, yeah.
Okay,
yeah.
so Mike Schaefer from the Department of Behavioral Health. So federal authorities have said, yes, you can share with a jail. Because you can share with the jail mental health provider because that's provider to provider, and under continuity of care, under HIPAA, you do not need an authorization to share. It becomes a little bit more questionable whether you can share from a provider to a jail. So for me to call the superintendent, for me to call Superintendent Smith and say, John has schizophrenia, he takes his medication, it gets a little grayer. Where it gets a little challenging here is you have to remember every CSB is advised by either their city or their county attorney. They all interpret HIPAA very differently. Delegate Watson and I have had this discussion about the interpretation of the code is so variable that even if though the feds have said, yes, you may share, I have heard stories of a locality where they're saying, my county attorney says, no, I can't share. And so then the CSB can't go against their own attorney. And so we've struggled with this and say, so we get the OAG to give an opinion. But again, they're not going to represent that county if there is a lawsuit against the county for mishandling information. So part of it is, if I guess, as I think Delegate Watts or Senator Howell said earlier, of maybe clarifying the code, thou shall share under these situations. HIPAA is interpreted this way in the Commonwealth. I think you go a long way to addressing this because I think people want to share, but they're just told by their supervisors they can't.
Delegate Synergies.
Mr. Chair, my reading on it is that we are too cautious because we don't understand. And we probably need to work from an Attorney General's opinion and work on some legislation on that basis so that everybody sings from the same sheet of music.
Sure. And along those lines also, that we heard from Superintendent Smith earlier about the jails sharing the information back with the CSBs. That all stemmed out of, we did cross-systems mapping started in 2008, and that was the best practice we shared with all the communities to do. It is not legislated, but that might be a step to do a requirement that the jails and the CSBs have this open communication while we're working on this AG opinion, because that way, at least the CSBs are knowing, oh, John, I haven't seen John in 2 days. Oh, John's arrested. They can then, start working to figure out what's going on with John.
Delegate Watts.
I know that I can add anything more than what's just been said, except to underscore my experience is that you really need the affirmative, you shall share, because otherwise the interpretation over the history of HIPAA, everyone's experience is different that they bring to the table, and there's been so many different interpretations that it's very hard to counter that in jurisdiction by jurisdiction.
Okay, so let me ask the CSB. So, Ms. Faison, so number one, I want you in the jail. You've said you don't like that. Number two, in theory, I could say you shall have oversight over the employees. So they're not your employees, but you would have oversight. I suspect you would say that's as bad as, if you're going to do that, you may as well have your people in the jail. How can we make it so that every day, the jail sends you a list of people, every day you look through the list, and every day, and when that happens and you see Eddie is in there, you then share the information that we then clarify you can. In other words, if we say you can send them that Eddie's current diagnosis is X, Eddie's current treatment is Y, all right, jail, go do your thing, but at least now you have the information. And by the way, we'll be there in 45 days for the transition at the back end when he's coming out.
Or just a basic health information exchange, and what would be the parameters on that? Something
Well, to provide the
those
jail health care with the information, they need to be more effective when they're providing.
I would be happy to take that back to the association and ask them, how they think that could work.
Okay. I'm thinking that may be a way to.
I would
Yes,
just say, Mr. Chairman, you could have reams of information, psychotherapy notes and formularies and everything else that John Smith is on. And how do you communicate that to the jail? I mean, maybe you need an electronic medical record that links the CSBs to the jails. That's another expense, but
I would hope we're all trying to get to the same goal, which would be you have this magic moment where you know where he is, you know what's going into his body, you know what's not going into his body. I mean, jails are terrible places to provide mental health care, but there are some aspects that they do make easier. And he's going to come back out and be yours again in 60 days or 90 days or 120 days. We would like him to be in the best shape he can be when he leaves. I don't know, I'm not visualizing the 6-inch file physically is taken from the CSB, but some way to give the current, again, just current diagnosis, current treatment. Okay.
So what, just so I'm clear, we're talking about a way for a jail to notify the CSB who they have
Right.
today, and the CSB would then be responsible for checking to see if any of them were already clients of the CSB, and then communicating appropriate, some list of appropriate information back to the
Some
jail.
way to get information to the jail so that if they don't use the CSBs to do the treating, that their treaters can take benefit of all that information that you have. Yeah,
Sure.
I mean, that would be,
All right,
okay.
I will take that back and certainly circle back with this group on that.
Delegate Watts.
Mr. Chairman, this may be appropriate or may be taken care of. While we're on this general subject, if an inmate has a private provider, I'm hoping that the code would treat the inmate's identification of that private provider and the affirmation of the sheriff with the private provider, that all of the records would have the same status as we're talking about as far as the CSB, that there wouldn't be a question that this is the wrong prescription for you. This is, anyway, that same linkage made to private providers. If that's necessary in the code, we need to make sure our language doesn't just point to the CSB.
I could visualize that'd be easy or almost impossible based on what the code looks like. I don't know.
Well, I was going to ask Delia Watts, I mean, if we did that, would the onus be on the jail to contact the private provider?
I'm going anecdotal in several different anecdotes where the parents in particular may be aware, or a spouse may be aware, and having a very difficult time working with the sheriff to have medications available for the person who's incarcerated that are appropriate for the person. And I want to make sure that we don't inadvertently only point to the CSBs and not treat but the onus would be on the individual who is incarcerated, obviously family members, to inform the sheriff.
Okay, I think you have some things that you might, Ms. Faison, I think there's some information you could take back and coordinate with Charles. And Charles, I hear about 5 or 6 ideas, some of them in conflict here, but they might be worthy of, this doesn't sound like this is quite ready for us to vote on. But if you come back with your thoughts and coordinate with him, we've got about a month. Okay, so I think it sounds like some things are ready, right? I'm gonna keep looking to you, Senator Deeds, in case you want us to slow down, but if we're ready, then, so. Oh, I'm sorry, ma'am, I apologize. Please, tell us your thoughts.
I don't know for sure who you are, but I would like to say thank you very much and hallelujah.
Oh, there we go.
Because that is a resource that is overlooked, ignored, dissed, and some of us are the ones that really know. Nobody knows more about the care that my husband has had, the meds he has been on, the things that work for him, the things that don't work for him. Nobody knows that better than I do. Most of the time that we've been married, I have had a power of attorney for when he was unable to make decisions for himself. However, that is not given very much importance by jails, by Central State Hospital, and by CSBs. One thing I would like to caution you in terms of making standards is one size does not fit all. And it does not fit all not only in terms of diagnosis, but in terms of causation. So often when certain types of symptoms are seen, conclusions are jumped to. Medical tests are not done. But the list of secondary psychosis grows by leaps and bounds every year. We have had some national stories that have shown the folly of doing that. The football player for the Patriots, I think, who they only found out after he was dead and they did an autopsy about the brain lesions and the brain tumor. People need to be medically tested. There are any number of things that could cause these things, that determine behavior, and they're not looked for. And in the words of one psychiatrist whose blogs I have read, if you don't look for it, you don't find it. And these are important issues. My husband in particular is very sensitive to certain things. And one of the medications that just absolutely is ruinous for him is the one they always want to give him. So I hope that this will be paid attention to and that there will be some sort of protocols put in place where family members will be asked, or even to ask the inmate or the patient, is there somebody who knows? Is there somebody you want to share this with? It would probably save a lot of money. Thank you.
Thank you. Okay, anybody else? Okay, so Charles, it seems like we had several that sounded like we were ready to go. Do you have the language for this, if you will, the Donovan language that was requested by Mr. Jones? Can you make that, if we want to include that, can you include that? I think all of us on this panel have voted for that language then.
The issue with the Donovan language that needs to be, I'll say, a little massaged is that the Donovan language specifically mentioned, and the language specifically reads that such agreement shall include a process by which the Community Service Board providing mental health services in a local or regional correctional facility shall bill the sheriff or superintendent shall pay pursuant to 53.126. In the mental health standard bill that was passed out, we don't specifically mention Community Services Board providing these mental health services. So while we can put that language in, it's not I'll say it's a 100% fit, because we don't talk about in those standards that CSBs are going to be the ones providing those services in jails. We leave that.
I think everybody wants to get a price tag for this. Can you get the price tag if we don't pass it, or do we need to pass it, as we sometimes say, in concept? And then you can get the price tag and any final language together by full committee.
I can do that, Mr. Chairman.
Is that okay, Mr. Chair? We usually want to see the language, but in this case, they want to see the price tag. Okay, so with that, I'll entertain a motion on the bill, and understanding that it's at least partially in concept, or the final language is not worked out. I'll entertain a motion on that. Okay. All right, the motion is made and seconded to recommend, I guess, reporting? Is that reporting. All in favor signify by saying aye. Aye. Opposed. Okay. Charles, which other ones were ready? You had the one about the mandatory outpatient treatment. And that's also, we're going to want a price tag on that also, but.
Yes, that's correct, Mr. Chairman. There's the one dealing with mandatory outpatient treatment, eliminating the need to have
Consent.
Correct.
Okay. All right, I'll entertain a motion on that one. Okay, made and seconded to recommend reporting. All in favor signify by saying aye. Aye. Opposed. Okay. Mr. Quagliati had two others that were not as sort of big picture. You had the reporting requirement from the courts.
That's correct. One was the specialty docket reports, directing the Office of the Executive Secretary to develop a evaluation model and report to the General Assembly on specialty dockets.
Okay. I'll entertain a motion.
So moved.
Okay. All right, the motion is made and seconded to recommend reporting. All in favor signify by saying aye. Aye. Opposed. Okay, I think there's one more besides the CSBs, which we're not going to vote on today, I don't think.
And that was the DCJS training standards.
Yeah.
For persons in Intercept 1.
Okay. I'll entertain a motion on that. Okay. Okay. Do we have our quorum? Did we just lose our quorum? Do I need Patrick or Janet back? With Senator Deeds, one of the four?
Oh, yeah, we did one.
Can you ask Patrick to just?
Yeah.
He's in the room.
Well. Could you stand in the doorway? Could you stand looking agreeable in the doorway? We just need our quorum. Okay, yes, all right. All in favor signify by saying aye. Aye. Opposed. Okay, thank you. Okay, Mr. Chair, we're going to put off the CSBs till we get a couple of options and hear from the CSBs. I think that finishes our business for the subcommittee.
And we have 10 minutes.
All right, anybody else have any more business before the subcommittee? The full committee is going to meet in 10 minutes. All right, we will be adjourned.